Dr. Ali Daud Kamal. He will be joining us on Zoom. And he's consultant physician, diabetes and endocrine and acute medicine at Heartland Hospital, University Birmingham, NHS Foundation Trust. He has special interest in complex type 1 and type 2 diabetes, and he is also running acute medical unit. So we will be joining him online.
Assalamu alaikum, and thank you for the invitation. I'll try to keep to 15 minutes, but I think the talk I designed is for 20. So let's see how we go. I think my friends at the Pakistan Endocrine Society were especially thinking of me when they chose this topic, tiredness and fatigue. We all know that tiredness and fatigue actually encompasses all of medicine, really. But I'll try to see what we can make of it. I make no apologies for the fact that I'm a physician first and an endocrinologist afterwards. I think if someone diagnoses an endocrinology condition to you and say, go and manage this patient, it's much easier. But you have to weed out the cases from the general mix that comes to you. So first, let's start with the definition. Fatigue can be defined as it's a subjective thing. People feel it differently. It's a symptom of exhaustion during and after their normal daily activities, or lacking the energy to do any of your normal activities. Tiredness is defined as lethargy with no desire to sleep. Now, there's an acronym for this condition in UK. Primary care physicians and other physicians also know about it. It's called TAT, called tired all the time. It's a heart sink sensation symptom. Patients have it's very difficult to actually focus and bring to the right diagnosis. So I think my objective of my talk, the first part of my talk is going to be involving general medicine, and the second part will be around endocrinology causes for this. It's a vast subject. You can go and read Harrison if you wanted to, but I'm not going to do that because I've never read all of Harrison. You can very easily end up doing lots of investigations and making the patient bankrupt. But what I would try to do in this talk is to make out a roadmap for investigations, how we can proceed in a systematic manner, and then we'll talk about the endocrinology causes as well. So first of all, I think the most important thing is the history. You've got to take the history right and need to clarify from the patient what they mean by tiredness and fatigue. The next important thing is to find out the onset, the duration of symptoms, the severity, and what are the precipitating or relieving factors which are involved. Why is it important? Because recent onset means within the last month, let's say. Prolonged means lasting between 1 to 6 months. Chronic would be more than 6 months. And there is a reason to classify it in this manner, because if the onset is sudden, you're looking at things like infection, toxins, post-traumatic stress. Gradual onsets could be heart failure, liver failure, kidney failure, metabolic abnormalities, diabetes, and many other endocrine causes. Persistent fatigue that is worse in the morning may suggest depression. And our depression is something which is going to underlie a lot of these, which could be on its own, or it could be part and parcel of the actual medical condition that you are treating, or you're going to treat. So what do the patient's perspective on all this? When patients come to the doctor, they usually think that it could be some infection that is doing this. When they come to the endocrinologist, they have got it in their mind that there is a deficiency in their system, a hormone or something, which can be corrected and they'll be back to normal. What they never think about is it can, rather than a deficiency, it could be a deficiency, but it could be an excess of something as well, excess of an hormone. So the causes could be psychological, physiological, or physical. So, I mean, the things to consider, and just a few general things. Sleepiness during the day could indicate sleep apnea, sleep disorders. Muscle weakness could point towards a myopathy, neuromuscular cause. I think the other common thing to think about is medication-related tiredness and fatigue. A lot of people would self-medicate sedatives, hypnotics, antihypertensive medications such as beta blockers. In people who have got hay fever, using antihistamines, herbal remedies, lots of stuff. Um, I mean, I think when I was used to work in Pakistan at that time, one of the drugs that were used most often, self-medicating, was drugs like Lexotanil and drugs like that. So people do that and just exacerbate the problem. A few things about chronic fatigue syndrome, and I've got a slide or two at the end of this to talk about that. Sleep disturbance, fatigue. Specific points to consider in taking history is appetite. I mean, poor appetite could indicate serious pathology, but poor diet and inadequate hydration, especially in the hot weather, could lead to fatigue. We had earlier talk a lot about menstrual cycles, the gonadotrophins and everything. So one of the things which goes off quite often early in any endocrine disorders is the menstrual cycle. So asking questions about the menstruation and cycles is important. Neurological symptoms like Parkinson's disease, multiple sclerosis, other things. These things also should be part of your history. Polyuria, nocturia, kidney disease, diabetes, and of course, we live in the age of infections. We have the COVID, TB, other infections, enteric fever. If a patient has had these infections, the tiredness, fatigue, the symptoms can go on for quite a while afterwards for recovery. In the history, do probe them with regards to signs and symptoms of inflammatory disease and autoimmune conditions like thyroid, Addison's, celiac, inflammatory bowel disease, joint problems. But remember, patients who have chronic diseases such as COPD, heart failure, liver disease, chronic skin conditions such as eczema, they also would have tiredness and fatigue. There are many reasons for that, lack of sleep, or it could be down to the biochemical level where they have got producing these chemicals which contribute to the tiredness and fatigue sensation. Right. So continuing on with that, probe a little bit into anxiety, depression, sleeping patterns. Doctors who do night shifts, their sleeping pattern is all messed up. Frequent travel to meetings and stuff, not happening very often these days. Stress, sleep apnea, all these. Family history is very important because that may be at the back of the patient's mind. They're worried about because so and so in the family, cancer, diabetes, they're worried about it. So that you must take into consideration what the patient's perspective on their symptoms is going to be. Social history is very important. There could be factors within the family which could be contributing, so relationship problems, child issues with children, money problems, financial matters, lots of caffeine, smoking, occupational history, and then conditions such as tropical infections, Lyme's disease, or a dengue fever even, all these things. So this is just an overall things to consider in your history taking, and must think about these things. Now, the red flag signs, this is where you start getting worried. Like if patient has got unintentional weight loss, like 5% of the body weight over 6 to 12 months, may suggest a neoplastic disease, Addison's, diabetes, hyperthyroidism, thyroid problems. Nighttime sweats, lymphadenopathy, fever may indicate cancers, may indicate chronic infections like HIV, lymphoproliferative disorders, TB. Ask about symptoms of hemoptysis, whether they have hemoptysis or whether they have experienced any dysphagia, rectal bleeding, altered bowel habit, breast lumps, postmenopausal bleeding. All these things I think they look a lot, but when you take a normal history, you would go through these things, and most of this could be, but you have to probe a little bit sometimes. But some people are very expressive and they give a lot of history, others are not, and you have to probe. An idea about their mental health, muscle, joint pains, neurological signs suggesting a neurological disease. Right. Okay, clinical examination should be based on the clues from the history. I mean, you don't have all day to examine the patient, so it has to be a targeted clinical examination, and including some mental state examination. Look for the general appearance about pallor, lymphadenopathy, jaundice. Get the weight, height, BMI, blood pressure, temperature, pulse. This is just to start off with. Now, first line investigations, what we would recommend is full blood count, as you know, looking for anemia, signs of infection, CR or picking up a lymphoproliferative disorder. ESR, CRP would point towards connective tissue disorders, even malignancies. LFTs, UNEs, TFTs. Now, these are the baseline tests you should do for these patients. HbA1c for diabetes, do serum iron studies, B12, folate. Now, the thing is, if the patient is iron deficient but they're not anemic, you still should replace it with iron. Do a urinalysis to pick up kidney diseases, celiac disease, CK for muscle disease. So these are the baseline investigations that you might. It will probably, I don't know how much it would cost, but probably not as much if you were to go down more second line of investigations. Or the next bit would be on a case-to-case basis, you could do myeloma screen, suspecting calcium level. Calcium levels actually should be in the first line of investigations because it could be quite relevant. You could do vitamin D, infectious mononucleosis, HIV tests, chest X-ray to pick up for tuberculosis and things like that, or sarcoid or any other malignancies if you're suspecting, if they're losing weight. Now, I'm going to move on to, of course, what you're all here for, endocrine disorders, and try to show. I mean, a lot was covered in the first talk that earlier, just before mine, but I was going to just give you a slightly different perspective on a few things. Now, adrenal insufficiency, a classic endocrinological condition, quite often suspected but not always diagnosed. I think what you should be aware of is that more common is a relative cortisol deficiency. Of course, fatigue, tiredness, is a main feature. Considering patients who have previously been on steroids, now in the COVID era, nearly everyone has been using steroids there. So if they become ill afterwards for another medical condition, they could be relatively cortisol deficient and they would become quite unwell. One of the things that I wanted to share is that in the University Hospital Birmingham Trust, we have this flow chart. I want to just, on the left side of the chart, you have the treatment for acute Addisonian crisis, but I want you to consider it on the right side. So it's not possible to do a senectin test for each and every patient that you suspect to have a cortisol deficiency. So what we have is, we have this morning cortisol. So here it's quoted in nanomoles per liter. So if the serum cortisol is more than 350 nanomoles per liter, a cortisol insufficiency is unlikely, so forget about it. If it's between 150 to 349 nanomoles per liter, it's possible. Start the patient on hydrocortisone and arrange a senectin test at a later stage. If it's less than 150, it's likely that the patient has a degree of cortisol insufficiency. So start the hydrocortisone. You could convert that into the local units that you use in Pakistan, but this is very helpful because previously we were all going about senectin test. It's not always very easily done. We have talked about hypogonadism in the previous talk, but again, low energy, tiredness, fatigue, quite common. So again, the test, 9 a.m. testosterone. Treat the cause if you can, but otherwise just start with the hormone replacement because it's a common cause for tiredness and fatigue. Now, diabetes, either a high blood sugar level or a low blood sugar level can both lead to these tiredness and fatigue symptoms. So if you know about HbA1c, but hypoglycemia, it could be medication related. If someone is controlling their diabetes very tightly with insulin or sulfonylureas, or it could lead to tiredness and fatigue symptoms, especially if they have had overnight hypos and not been aware of that. So check fasting glucose in addition to HbA1c and testing blood sugars, kit with them as and when they have their symptoms at their most pronounced. Thyroid disorders, an overactive thyroid and underactive thyroid, both will give you tiredness and fatigue. But what you got to be aware of is if you got an overactive thyroid and you're treating it with carbimazole, it may be that the dose is insufficient. The TSH takes a while to get into the normal range, but you should check the T4 levels in case you have to adjust the carbimazole dose. Undertreated hypothyroidism, you got to make sure that the TSH level is between 1 and 2. So if they are on an inadequate dose of thyroxine, you have to adjust the dose of the thyroxine. Now, Cushing syndrome or excess cortisol, if you have the clinical features, if you're suspecting someone is overweight and newly diagnosed diabetic, hypertensive, muscle weakness, so simple test to do. It's a very difficult diagnosis to make, but you can screen patients out, giving them 1 milligram overnight dexamethasone suppression test, give them a milligram of dexamethasone at night, check the 9 a.m. cortisol. If it's less than 50, unlikely the Cushing's. Can do it. A second test is usually required. It's a 24-hour urinary-free cortisol. So again, this is another endocrine condition which presents with fatigue, tiredness, as are most conditions. Do not forget about bone stones, groans, and psychic moans, hypercalcemia, hyperparathyroidism, vitamin D, taking too much vitamin D, malignancy. Check the calcium levels. It may be something that points towards a different diagnosis, and you can go down that path then. Vitamin D deficiency, a lot has been said. Even in a sunny country like Pakistan, there's a lot of vitamin D deficiency. You guys know more about it than I do, but fatigue is a common symptom, and that should be looked into. You don't not necessarily have to do vitamin D levels to confirm that. You can just start them on based on a history. Adult growth hormone deficiency should not be checking for growth hormone IGF-1 levels unless there is a history of pituitary disease. Unless someone has had some hypopituitarism or pituitary tumor treated, do not test for it. It's not recommended. Again, this will cause tiredness and fatigue. Sleep apnea. Most of the patients that we see with type 2 diabetes are overweight, and we are focusing on their diabetes. Still, they are feeling tired, fatigued. They've got a lot of symptoms. Think about sleep apnea. Unless you think about it, unless you ask them about the snoring and the daytime sleepiness and all that, look into it, and this could be a reason for their tiredness and fatigue. Long COVID now, lots of symptoms. You can see the whole list. And these can go up to 6 months. And tiredness, fatigue is the main symptom, but there are many others. Some people are left quite disabled following that. For this reason, there has been Covid19 clinics been set up in some trusts, not in our trust yet, but where there are cardiologists, hematologists, renal physicians who see patients. These are patients who have suffered microvascular damage to the myocardium, to the kidneys, and they're followed up and with different, they're set guidelines and pathways to follow through with this. So take that in mind. You will have a lot of patients like this coming to you. And they're not just all in their mind. They do have a physical basis for the symptoms. I'm towards the end now, if the admin is getting a bit worried. Chronic fatigue syndrome, a heart sink sort of scenario. Fatigue is nearly 100% this symptom in this condition. There's no test for chronic fatigue syndrome, but there are clear guidelines for diagnosis. They've got lots of symptoms, headaches, memory problems, these things. Some people are left quite disabled and are bedbound for years on this. The treatments that are recommended is cognitive behavior therapy, CBT, GET, which is graded exercise therapy, management diary, diary of daily activities. Some medicines like tricyclics, SSRI, even some people have used acupuncture. Lifestyle changes like diet, sleep, rest, relaxation. Think about work. If the work is too stressful, changing the line of work. Equipment which helps them get through the day if they are quite disabled by it. So actually, I'm done. I think I probably kept time. So again, just to highlight, it is a very common symptom, but you have to weed out a lot of things and not to miss the red flag signs. Endocrinology nearly is all of tiredness and fatigue. There's syndromes like FUES and others which have already been discussed. all of them. But if you stick to a roadmap, do the initial tests, and then with the history, be guided towards a more specific test so that you save patients resources and get them to the right diagnosis. Thank you very much.